We're here with Dr. Zeeb.
And Dr. Stoner.
Yeah, that's right. I'm Brady Settlemeyer from Violet Township. Hope today you guys can refer to me as Nighthawk.
And this is Michael Proctor from Violet Township as well, and I'd like to be addressed as Dragon.
And we would suggest that you guys pick some pretty good names too.
Okay. Just call me Doc.
I wanted that one. Dang.
You can be Doc too.
I can be Doc too. Kid Doc.
Doc 1, Doc 2 then it is.
I guess. It's like a Dr. Seuss book.
Well, you have to present to your audience.
Got to be a child, I guess, huh?
So anyway, this is something we've done every year for this is our third or fourth time, doing a review of the protocol assessment that we distributed in January. So we're recording this on January 4th. The protocol assessment has been sent out to the EMS coordinators. You should be seeing it within the next week. And just a few comments. We have a protocol assessment we want to use as a learning tool, as a source of discussion among the crew members. So it is an open book. If you think you need to look at the protocol, look at the protocol. Look at the app, whatever you think you need to do. Some of the questions are very similar to ones we've had in previous years, or if not identical to previous years, and that's because Dr. Stoner and I think sometimes we need to emphasize things. Group participation is encouraged. From my perspective, this is an ideal circumstance for the on-duty crew to sit down, watch this video, talk through the questions, and answer the questions that you have to answer the questions on the answer key, just as a group discussion. This is pass-fail. There is no threshold to pass. There's no passing grade, but to pass, you have to take the assessment and you have to look at the video. So we really want this to be a learning tool for everybody. And I can guarantee you it's as much a learning tool for me sometimes, because when I write the questions, honestly, I have to go back and open up this response off the app to make sure I'm answering the question the right way. So just a quick sidebar, and this has nothing to do with the assessment, but just a quick review of IV Epi. A couple weeks ago, a couple departments brought up, hey, we've looked at the protocol, we have concerns over our dosing schedules for intravenous epinephrine. And I looked at it, and for children, it was pretty good. For adults, we had some diagnoses or conditions. You're supposed to do a certain micrograms per kilogram per minute. And in other portions of the protocol, it says 2 to 10 micrograms per minute per the drip protocol, titrate to effect. Well, so we went back and took a look. So we had the inconsistencies for pediatric and adult cardiac arrests, no change in terms of epinephrine dosing. Intramuscular epinephrine, principally for anaphylaxis, no change in dosing. Push dose epi for DSI, no change. But for pediatric bradycardia and post-arrest stabilization, we now have it consistently as 0.01 milligrams per kilogram, IV push every 3 to 5 minutes. For me, the easy way to remember it or to dose it is, if I used a 1 to 10,000, which is what we want you to do, it's 0.1 milliliters or cc's per kilo. So 7 kilo kids, you're going to dose that if they're going to get 0.7 mLs of 1 to 10,000. For adults, we're just going to go to the infusion of 2 to 10 mics per minute per the EpiDrip protocol that's in the protocol. So if your patient is bradycardic, if your patient is hypotensive, your patient is septic, and you think they need IV epinephrine infusion, it's use the drip at 2 to 10 mics per kilo. Do that and titrate to effect. So for the hosts, any questions about that? I think it's a good idea. And honestly, one of the departments that picked it up is because they're doing the competencies, and they realized when they looked at the protocol for the competency they were looking at, depending on which page they looked at, the algorithm was different. Hopefully we're consistent.
Good. Consistency is wonderful.
All right, question 1.
That's right. I'm still caught up in group participation.
All right.
You're a lot better with that.
I like the whole testing things, pass-fail, just to do it. So.
Yeah, well, I was thinking about going to a pass-fail college, and then I realized with pass-fail I would never get into medical school. Those days they wanted a numeric grade.
Hey, at my level, participation's the best you can get.
All right.
So.
Yeah.
All right,
so anyway,
we'll start out with this one. So you have a 25-year-old male with this type of injury, a burn to looks like his leg there. This is his only injury, and there's no inhalation injury. What treatment options may you offer to control his pain? So starting from basics all the way up through, what will we do there, Doc?
Well, we've got IV fentanyl as an option. We've got the burn gel as an option this year, which is principally why this question is here. Topical lidocaine, intramuscular ketamine, or A, B, and D. So for my choice, I picked A, B, and D. Those are all appropriate treatments for pain and or burns. Topical lidocaine is not something we've ever really discussed, but topical lidocaine can be absorbed cutaneously. Depending on the size of a burn, you can develop lidocaine toxicity. So we're not going to apply topical lidocaine to this patient. So I just threw that in there as an answer. But topical lidocaine probably would be effective, but patients at risk become lidotoxic.
So then our IM ketamine would just be for increased pain that our fentanyl is not.
Well, keep in mind, IM ketamine can be given for an adult at 50 milligrams IM as a single dose, regardless of the patient weight. So you have a patient with an acute traumatic condition that's painful and you want to control pain, you can give them, and you don't have IV access, you can use intranasal fentanyl, you can use intramuscular ketamine. IM ketamine works great. In 3 to 5 minutes, the patient is much more comfortable and usually can be managed. I've had patients with opioid addictions who come in, we can't get IV access, they've got a painful injury, IM ketamine, in 5 minutes they're purring like a kitten. And they're saying thank you.
Cats still say thank you.
Yes. Purring like a kitten. I like that terminology.
Are you going to read this one, Mike, or should I read it?
How about it, Brady?
Yeah, I can't read very well, but we'll try it. You elect to treat a patient with burn gel. When should you not use burn gel? A burn surface area of greater than 10%. An ambient temperature is 10 degrees and the patient requires a 20-minute extrication. The patient has diabetes, or A and B.
Yeah, typically, if you know I'm writing the test and you always have an A and B or more than one answer, that's probably the right answer. To keep that in mind for future questions. But keep in mind, we've added burn gel this year. Did so after consultation with one of the OSU burn surgeons. And her recommendation was that we use it, but not use it in patients with a BSA more than 10% or patients who are at risk for hypothermia. Brady asked, why did I pick 10 degrees? Well, it's not the 10 degrees, it's the fact that it's cold outside. The patient's going to have a long extrication. They are already at risk for hypothermia, and we want to avoid further heat loss, so we're not going to apply the gel, regardless of the size of the burn, if the patient's at risk for hypothermia. Diabetes has no status in terms of whether or not you use this. So for me, the correct answer is A and B.
So all in all, we're not necessarily worried about the 10 degrees. It's just the fact that it's going to be cold outside and there's a prolonged extrication.
Yeah, and the patient's at risk for temperature loss, heat loss, just from the environmental exposure. We're not going to add to it by adding the burn gel. Just like we're not going to throw a bunch of ice water on them either.
Simple terms, goo will make you lose heat faster.
Yeah, I've heard that.
All right, time for Dr. Stoner.
Am I ready?
You ready? I'll read.
All right.
All right, your team is called to a 10-year-old with a history of epilepsy for a prolonged seizure. There is no history of trauma, but she has had a sore throat for the past few days. She is normally on Keppra, but has missed a couple of doses. On arrival, she has continued to have convulsions. What should we do next? So A would be intubate her and protect her airway using the DSI protocol. B is administer a weight-based dose of Versed intranasally using the MAD device. C, apply pressure to her nail beds to see if she will come out of it. 3, check a serum glucose. And E, establish an IV and administer a weight-based dose of ketamine through the IV.
So, I didn't give you multiple choice like Dr. Zeeb. Basically, you want to stop the seizure as quick as possible. And of those, do you want to protect her airway? Well, if the seizure stops, it may not become an issue. And the best way do you want to see if she's responsive? You already know she's not. So the best way to do this is, I chose B. Give her, I don't know why the device is mad. It's just angry because it must be a holiday. But give a dose of intranasal midazolam to break said seizure, and then you can move on from there. Obviously, sugar is important, but the first thing you want to do is break that seizure. So that's why B is the answer.
Yeah, so most of these are may be indicated at some point, but it's that first step. The key part of the question is, what do you do next?
Stop the convulsions, then go about your business,
Yep.
etc.
Stop the seizure first.
All right.
Caring for a 70-year-old female who passed out for 3 to 4 minutes. The event was witnessed by her husband, who helped her to the floor. She is now awake and alert without any visible injury or complaint of pain. What is not, key word is not, an appropriate action? Obtain a 12-lead finger stick, administer Narcan, a stroke screen, or obtain orthostatic vitals.
So I put this in there because we've recently, or with the 2023 protocol, we kind of broke the syncope unconscious down to unconscious and syncope. This patient is awake and alert. And so, what should you do on the scene? So if you think about it, the patient's awake and alert. Narcan is not indicated, but I'm just bringing attention to the portion of the protocol. If you look at syncope, the middle column, we're going to get an EKG. We're going to obtain orthostatic vital signs. We are going to check a finger stick blood sugar, which is actually further up in the algorithm, and orthostatic vital signs are important. It's amazing how much our cardiologists rely on EKGs and orthostatic vital signs in making determinations of what happens with a patient next. Really, we should be doing 12 leads in the field, and you should make sure that a copy is with the patient or you transmit it to the hospital. There have been multiple times where it's the pre-hospital 12 lead that results in certain defined patient care. And that's particularly true for patients with VT or VF, and the cardiologist doesn't have anything to look at. But if you can get that 12 lead or that rhythm script to the cardiologist, they can then make a diagnosis and maybe avoid testing on a patient when they just need an AICD implanted. So for this patient, they're awake, alert, got spontaneous airway. The thing you don't do is administer Narcan.
Perfect. Nighthawk, I think it's kind of funny. You bring a question up about being appropriate.
Oh, Brady?
Nighthawk, yes.
Yeah,
Oh.
Nighthawk. Yeah.
Okay.
Doc 1, that's Doc 2.
Okay,
We got
you were
it.
looking at me and I think
Yeah.
No, I was going past you there.
Okay.
So.
I don't know what you're trying to say there, Greg.
All right, next question. Is this a Brady question?
No.
No, that's Greg on the end there.
Yeah. We'll give this to Dr. Stoner.
That's a short one. He should be good with it.
I've practiced it a few times. So, when treating acute asthma, there is a difference in the route and frequency. Is there a difference in the route and frequency of administering a Duoneb versus albuterol and Atropine?
You got a 50-50 shot on this one.
Is that what it is?
Well, it should have been, the way it's worded, it should say yes or no
Oh,
instead
like
of
a
true or
25%
false. But,
shot.
Yeah.
I'm
So-
We'll let it
realizing
slide.
that now.
Because it's on a slideshow, I get it.
There is no
Slide.
difference. When
You see what I did there?
That's it.
That was good.
That's good.
So the answer is false. There's no difference. It's the same medicine, just in 2 different vials versus 1 vial.
Yeah, it's a change we made, just assist in work practices. Instead of opening up 2 vials, you just open up 1 now.
And it's-
And if you have some albuterol and Atrovent left on the truck, use it until you use it up and then switch over to do it now.
Perfect.
Work
0.3
smarter,
cents
not
cheaper.
harder.
Yes.
Right?
Right.
Nighthawk.
I'm up. You successfully intubated a patient utilizing ketamine and sucks. Following intubation, you administer fentanyl and midazolam per protocol. She is well sedated, and your transport time to the emergency department is 7 minutes. Should IV rock be administered?
So I stuck this in there because this year some of our departments may start carrying rocuronium. Rocuronium is a paralytic, and it lasts anywhere from 20 to 40 minutes depending on patient's metabolism. It's being added to the protocol because we've had some of our outlying departments begin to do interhospital transfers, and we've had a couple cases where succinylcholine was inadequate for patient transport, or they ran out of sucks before they got to the receiving facility and the patient was combative. So we've added rocuronium as a longer lasting paralytic. And we've got it set up so that it's department specific in terms of whether or not you put it on the truck, and the expectation is you're going to have transport times more than 15 to 20 minutes. So if you have a 7-minute transport time and you have adequately sedated the patient, you should not need rocuronium. So for me, the answer is no.
But in addition to that, too, you can also second dose.
You can also second dose
succinylcholine.
succinylcholine. But we've had a couple patients who just have gotten wild, and we were wishing that we had rocuronium on the truck.
Right.
The other thing is you have to have an airway in place. So rock can only be given after the airway is secured.
Perfect.
What's the time limit on sex?
What do you mean time limit?
How long?
It lasts 3 to 5 minutes.
Okay.
So I think when we added the succinylcholine into the the redosing of it, it took care of a lot of the issues that we were having
Yes.
with keeping people sedated. So I think this will work great for us to have those longer transport times.
The other caution would be with rocuronium, make sure the patient is sedated, and I would consider giving additional sedatives during transport if needed, because rock is a paralytic. It has nothing to do with patient awareness. So nobody should be aware and intubated and paralyzed.
So fentanyl, Versed, keep those on board.
Keep those on board.
Sounds like a Saw movie.
I think that was key. The kid still has there. The person still has fentanyl versus
It's a heck of a nightmare.
Yeah. Terrible.
I think it's you, isn't it? Me?
I just went.
All right. So question number 7. A 7-year-old girl with a tree nut allergy was at a birthday party and ate a delicious Nutella birthday cake. Didn't know those even existed. It had to be delicious. You find her with diffuse urticaria or hives and she's vomiting. What is the most appropriate next step? So A, give her a weight-based dose of diphenhydramine, IM. B, give her ondansetron followed by oral diphenhydramine. C, administer 0.01 milligrams per kilo of epinephrine IM 1 to 1,000. Or D, establish an IV and give her 0.01 milligrams per kilo of epi IV 1 to 10,000.
So I think, first off, my kids are making fun of me for using so many adjectives. Delicious cake. First thing you have to recognize.
Did you make this one?
I did.
Perfect.
First thing you have to recognize is that Nutella is made out of hazelnuts, isn't it?
Yep.
Which is a tree nut. And the second thing is to recognize this kid is an anaphylaxis. So it isn't just a rash. She's got a few different systems. She's got a rash going on, plus she has GI involvement, and she's throwing up. So you want to treat it as anaphylaxis and not try to just cover the symptoms up. The way to do that is with IM epi. So, C.
One thing that this question comes a lot to me because there's a lot of questions we're not asking. 7-year-old with a known nut allergy. Is it her birthday party? Did mom make the cake? Did dad make the cake? Like, there's a lot of suspectful stuff going on here that I'd like to know questions to
Probably
as well.
a father that made the cake and not a mother.
Well, we can't assume anything, so I think PD would be a good one to get in route too.
You're sounding like a cop.
He's a detective.
Yeah.
I am a detective.
Yeah, there is a common theme to this. This question or similar questions I think have been asked on the protocol assessment from the beginning. And it's because we still see patients that receive all sorts of treatment except for what they really need, which is the IM epinephrine.
Correct.
So it's one of those, some of these other things may be indicated. You give them epinephrine and they develop GI symptoms, well, maybe they need some ondansetron.
Right.
But the key life-saving thing is going to be that early administration of intramuscular epinephrine.
Epi will take care of your symptoms you're having, and diphenhydramine will take care of the cause.
Yeah, it breaks that cycle. Well, actually, the epi will break the cycle.
Correct.
And not all allergy symptoms are urticarial. It could be asthma, it could be edema of the airway, it could be GI symptoms. Right. And we often forget about the GI symptoms that may come with allergic reactions.
Sure.
Dragon, are you sweating over there?
I am. I'm beating up a little bit.
You were on a medic with 2 medics. You now have an 18-year-old male suffering an acute asthma attack. He is diaphoretic, alert, but agitated with nasal flaring, audible wheezes, and intercostal retractions. O2 sats 90%. What are your treatment priorities? Intubation, oxygen, rocuronium, Duoneb. Call for an additional company, high flow O2, Duoneb, IV, IM epi, Decadron,
Max sulfate.
yeah, MAG. Consider CPAP, prepare for intubation, IV access, Decadron, Duoneb, intubate, or Duoneb, set up CPAP, Decadron, and intubate.
This is probably the worst question I wrote, particularly the answers.
I picked the longest one.
Yeah, I always, again, it's
one,
test
yeah.
taking, go for the long one. I could have just had, intubation, call for additional company, IV access, or Duoneb. For me, it is the longest response, but really what I'm looking for is this guy's in trouble, this kid's in trouble. There's no way 2 medics with 4 hands are going to be able to manage this patient. my hope is you walk in the room and you're on the radio calling for help before you even start going for your drug bag. This patient is probably going to need interventions over and above IV access and doing that. So get the help started. If you don't need the resources after they arrive, that's okay. But I think we've all been in circumstances where we're in a pickle and we can't do the patient well until we get additional resources.
It's always better to have a company coming to help you out.
You can always
versus
cancel.
Not, if you don't need them, send them back.
Yeah, I mean, it's kind of like, look at all the resources we send at other events. This is one of those where if you need help, call for it early. And that was my only point.
I mean, if you have somebody that's in this type of shape that he is in, there's nothing wrong with getting a couple people on board and starting to get multiple things working at the same time, right?
Correct. Again, 6 to 8, 10 sets of 10 hands are better than 4.
Sure. So, Doc, of all these meds up here, me looking at them, if you have a guy that's in this kind of trouble, the most potent, fastest acting drug that we have on here is going to be our IM Epi, right?
Yes. IM Epi
open them up.
and oxygen.
And oxygen, right?
Oxygen, IM Epi, do a neb, and then I would worry about everything else. Because those are all things you can do without IV access.
Correct. So, my question to you, because we don't get that far along in a whole lot of this, our max sulfate, how quickly does that act, and is it something we would see in the field, where we'd see them open up and see the O2 saturations getting better, or is that something that the hospital would see after we drop them off?
I don't know. It depends on the patient.
Okay.
And how far you've been with them. For me, MAG is kind of something I give later on in the course. I might have a patient on CPAP or BiPAP before I have them on MAG.
I think if I walked in, if I saw this kid, this 18-year-old in the emergency department, I would jump right to the IM Epi and the oxygen while I'm setting a nab up, and then work my IV.
Perfect.
And we often forget the IM Epi these days. Before we had nebulized medicines, we would give all these kids would get intramuscular epinephrine.
I think.
And the other thing to think about, like dexamethasone, yes, give it in the field, but dexamethasone takes 2 to 6 hours to work.
Sure.
So you're just helping the patient a little quicker by giving it. But if the patient's better in 20 minutes, it's not the steroid.
Sure. So I think sometimes we forget about how potent of a bronchodilator Epi is.
Yes.
So.
Yeah. And they are going to get more tachycardic, and he may puke on you.
Sure. Treat the symptoms as they come then.
Yeah. Clean your shoes off when
Clean
you're
your
done.
shoes.
That's a great question, Mike.
Appreciate that.
That's real good.
All right, ready? You're on scene for a 12-year-old with a history of oppositional defiance disorder, the ODD, ADHD, depression, and anxiety, who is acting up, very anxious and agitated. He is having loud outbursts, but is not violent. Verbal techniques to calm the patient have been unsuccessful. Which of the below would you give this pediatric patient?
All right, this one I was just trying to make of as many behavioral health disorders I could think of.
Got one of these in my house.
Oh,
Maybe 3 or 4 of them. I
got-
got 7 kids.
okay.
So,
We got one sitting at the end of this table.
you.
That's the ODD or odd part. Basically, I took this one right out of the protocol, so this is follow along with your protocol of the different scoring of where we are with agitation and what medicines to use. The correct answer, and I took this from Dr. Zeeb, is all the above. Choose them all. But if you follow your protocol along, he's a 2?
A SAT plus 2, yeah.
SAT plus 2, which is where the violent part of that question comes in. He's not violent, so he's not a 3. So he's a SAT plus 2, and each one of these are option to give the person. If you have IV, you can do some IV ketamine. Otherwise, you have a ketamine or midazolam non-IV option.
And we have our choice of that, right?
Yeah.
We can
Yes,
pick
yes.
which one we want and go with it. It's not a, hey, try Versed first and then go on ketamine.
No, and we'll get to this a little bit later with another question, but really once you make a choice, and then you can repeat it if you have to, but it's the same drug.
Do you
Okay.
guys use a SAT system in the hospital?
I don't use it.
Because
might be
I'd say
more.
one thing with this protocol is having this SAT scoring is, yeah, we get a lot of behavioral issues, but it's pretty rare that we get to the point where we actually give something for the combativeness or harm to themselves or us. And then trying to remember that SAT score when you have to act quickly to give that drug. I mean, do you have any tricks as far as understanding that SAT score system better so we know You know, or would you recommend putting it up in the truck somewhere so you can?
I would, for me personally, I would look at it because I'm not really great at pulling this out of the air and kind of scoring somebody. I think if you do it quite frequently, that would be a different answer.
Sure, that's the thing.
I don't do it that frequently.
I think the big thing when you look at it, especially like the SAT-2, SAT-3, if they have combativeness with it, it elevates it to that 3, and you're going to go for
Big dose ketamine.
big dose
Yeah.
ketamine to be able to calm them down.
Yeah.
So,
The way if Brady, if you're looking for me, just if I don't have a resource available, it's going to be a little agitated. It's going to be some midazolam at a lower dose.
Sure.
If it's agitated but not violent, it's going to be either midazolam or a lower dose of ketamine. And somebody who's a threat to themselves or others physically, it's going to be the higher dose ketamine.
Okay.
And it'll probably be IM simply because if they're at SAT-3, trying to get IV access is going to be more dangerous than just giving them a shot and stepping back for 3 to 5 minutes.
Sure.
And you guys are really good at this. We had a really agitated father in the hospital, and we had security there and hospital personnel there, and then these 2 paramedics walk in, grabbed the guy, talked to him really nicely, and walked out with him. And I was like, you guys really did a great job just verbally de-escalating it. So,
Yeah.
we're a wonder with words sometimes.
yeah, that
And
amazes me,
looks.
actually.
You know,
Well,
some of us are.
You don't have to say anything. We know.
yeah.
All right. Question 10.
4-year-old male with history of autism and severe persistent asthma is being evaluated and is in significant respiratory distress. His respiratory rate is 52. He has global retractions and is unable to speak in full sentences. You immediately start albuterol and ipratropium aerosols and start thinking of next steps. Which of the following is appropriate to consider?
This is pretty much a repeat on the last one minus the intubation. Again, it's a pick everything question. The autism was just thrown in there by me to throw in a red herring to see if it messed you guys up. It has nothing to do with this question. But again, this is a sick 4-year-old, pretty significant asthma, and you're going to want to start thinking about everything you have in your toolbox that you can throw on this person. And again, it's IM epi would be where I would start with I didn't put aerosols because it's a given. Oh no, it's already started. IM epi would be the next spot I go, and then start thinking about your other stuff. As Dr. Z mentioned a few minutes ago, Decadron or dexamethasone, either oral or IV, is a great option. It's going to help us in the hospital later, but it's not going to help you out in the field too much, but it will help that patient recover quicker, hopefully, or not escalate as bad. So, everything.
Are we better off to give our? I know it said that you already started your aerosol treatments. But are we better off to put the CPAP on, then start the treatment if we can, so that it gets deeper, holds better, attaches better?
For me personally, I think it's easier just to grab the neb and get that going while you're setting the rest of the stuff up. So I usually start with the neb first and see how that goes. I usually, even if somebody's really sick in the ED, I will start with the neb to see how they respond to it. Some people respond very quickly and some don't.
Okay.
And I'm mentally preparing and physically preparing for that next step, which would be the CPAP.
That's why you're the doctor.
4-year-old with autism is probably going to not take CPAP well.
Sure.
So you could spend a lot of time trying to get CPAP on when you could have been given a blow-by or some type of a treatment. And then move on to CPAP if and when you think it's appropriate.
Sure.
And we kind of discussed this the other day, Mike. I think the epi in a respiratory distress with asthma outside of a allergic reaction, that epi is either missed or put so far down. You know what I mean?
Sure.
Because you hear that respiratory distress and the asthma, and all of a sudden you're thinking oxygen, duoneb, rather than just saying, hey, let's get this epi in because it works so well. And I think it's good to keep that in mind as, not just in allergic reactions, but when you get your severe respiratory with asthma as well.
So Dr. Zeeb and I both wrote separate questions. They both had it on there, so we're thinking alike.
A real quick question: if you do have a patient that's really bad, right? Let's say they're circling the drain, and the best thing that they're going you do get to that CPAP, but maybe they are severely anxious about it. Is it okay to call ahead or give some Versed to help with that anxiety so that they would tolerate that treatment better? If we did get to that point?
You're talking about children?
Yes.
You're gonna turf that, darn you. I will say I've done it, and yes, it's appropriate to do. It makes me very nervous because somebody who's really struggling to breathe, you're giving them something that's going to decrease their drive to breathe, in order to give them something that's going to help them breathe. So it's a balance, and you sit there and you try to figure out. So that question worries me. I don't want to just knee jerk say, yeah, just give them a bunch of
Sure.
Versed, but I have done it, and it is an option.
Have you ever noticed that children's with something similar to this where they're not going to tolerate it until you get that mask on them, and they get that breath and say, wow, this really helps, and they calm down like that?
Oh, all the time.
Naturally?
Yeah. Because they'll find, initially when it's on there, they feel claustrophobic and maybe having some trouble breathing, then all of a sudden they relax for a second and they're breathing so much
Right.
better. Yeah, 100%.
All right.
Now, for adults, sometimes we'll give them a little bit of ketamine or we'll put them on Precedex.
Okay.
Precedex is used a lot for vented patients, and it doesn't really suppress their respiratory rate.
Gotcha.
We use a lot of Precedex, but we don't have it on the trucks.
No, we don't have it on the truck.
Ketamine's a good. I
ketamine
glossed over that. Yeah.
It won't interfere with respirations. It may actually have some effect on improving their asthma. The only
Right.
problem with ketamine is it's going to probably have them with more secretions you're going to have to deal with.
Sure. Okay. Well, thanks for the input on that. Number 11. You're dispatched to a local extended care facility for a possible stroke. On arrival, you find an 87-year-old male with jerking movements of the right arm and leg, eye gaze to the right. Symptoms started about 10 minutes prior to the dispatch. Patient repeats, appears to be awake, and will repeat words when spoken to him. IV access is easily obtained. What actions are appropriate? So A is check a finger stick for a blood sugar, administer IV midazolam, perform a stroke scan, A and C, or A, B, and C. You're trying to trick us here.
Yes,
you
well,
did this
actually,
twice.
don't give me credit for. I really didn't put that much thought into it. But this is actually a case that I was with. I think it was with Jefferson. We took a run for Columbus, and they sent the stroke truck too. And it's an elderly gentleman. I think he was like 99 instead of 87, but he was having these exact same symptoms. And the question is, what do we do? And for me, I think this patient is having a seizure, but you still want to perform the stroke screen. You
Sure.
still want to treat the patient with IV midazolam or intranasal, and you still want to check a finger stick. Anybody with altered LOC, check the finger stick.
Sure.
So I think this patient was having a seizure, and when I talked with the crews, both the Columbus Engine Company and with the medics on the truck, I said, I think this is a seizure, and I think, and here's why. And his deficit was on the right-hand side, so his right-hand side was jerking, and his eyes were deviated to the right. So typically, when you have brain lesions that are destructive, like a stroke, the eyes go away from the side of the lesion, whereas with patients who have an irritative lesion, meaning something is irritating the brain, like a seizure, the eyes drive to the side of the lesion. So if the guy's moving his right side with a seizure, it suggests something's happening with the left brain, and the eyes are pointing to the left brain. So to me, that's an irritative effect, which to me means seizure.
Sure. But if they're going to the same side, you're thinking stroke.
Thinking stroke.
Okay.
So if his eyes were deviated, if he was flaccid on the right, eyes deviated to the left, then I would think stroke. And then I couldn't get rid of the thing about pontines. The pons is the base of the brain. The nerves have already crossed over from right to left. I doubt I will identify a pontine lesion based on physical exam. Neurologists do it all the time. Not me. I wait for the CAT scan.
Sure.
So, but it just, if the patient's having active seizure-like activity on one side, you would expect the eyes to be deviated toward that side.
Perfect.
Do you agree, doctor?
Your picture looked backwards. So. He's looking away.
No, cortical lesion is driving to the side of the lesion. Seizures are driving away, opposite side.
Okay.
Oh, wait a minute.
You said
I got it. I did get it backwards. Destructive goes for the side of the lesion, which is what I talked about, and then seizures go to the opposite side.
Looking away.
Yeah,
So your question should have been.
because a right-sided seizure activity coming from the left brain should
be
cause
right-sided.
right-sided.
Yeah.
So anyway,
Yeah.
Mike, didn't you identify a pontine lesion a couple weeks ago in the back of the
It was a
truck?
pontoon, wasn't it?
That's what it was.
Yeah.
Pontoon.
Yes,
It was a nice pontoon, though.
it was. It was floating right down the road.
Party
Right.
barge. Dispatch on a seizure. On arrival, you find a 28-year-old female who is 2 weeks postpartum. She appears postictal. Blood sugar is 125. BP is 160 over 110. 2+ ankle and pedal edema. What treatment do you provide? 2 grams of mag over 20 minutes. 5 milligrams of Versed. 4 grams of mag over 20, transport to a hospital with OB capabilities, or C and D.
And that it is C and D, and again, my own test writing skills right there. This patient, she is postpartum by 2 weeks. She is eclamptic. She had a seizure. Remember, patients can have eclampsia, depending on who you read, 4 to 6 weeks after delivery. So she is eclamptic. Her blood sugar is normal. She is still hypertensive. She has ankle edema. All of that goes along with preeclampsia, eclampsia. We don't need to give her midazolam because the seizure stops. So then it comes down to which dose of mag sulfate. So we have mag sulfate over 20 minutes or 2 grams for like torsades or asthma, but for patients who are eclamptic or even preeclamptic, our dose is 4 grams over 20 minutes. You got to be careful. The biggest problem with a high dose mag is respiratory depression, so you need to monitor respirations. N-title's perfect. And the other thing is, if you have a patient with a complication of pregnancies, they're in the postpartum period, they should go to an obstetrical facility.
Sure.
Because it's, when we see a patient who's had a seizure, who is preeclamptic or eclamptic, we send them right to L&D unless they have need for airway or something else. It's the obstetricians who have the expertise in managing this. So they get 4 grams of mag sulfate over 20 minutes and then transport to hospital with OB.
Reminder: there's no OB at Children's.
But you have capabilities of treating a little bit, right?
They can
Treating
they can
it-
Yeah, we
stabilize
can
and ship.
stabilize.
And ship, right?
Yeah. So if anybody's had a kid or thought about having a kid.
All right, number 13. You are called to assist another unit with a pregnant woman. On arrival, the baby is crowning, and the other crew states they will handle the mom and ask if you will care for the baby once it's delivered. Moments later, they hand you a wet, slimy baby who is limp and not crying. You warm, dry, stimulate the baby, suction his mouth and his nose, and get vitals. He has poor respiratory effort. The heart rate is at 65 beats per minute, and he is dusky in color. What is your next steps? So A, give IM epi. B, start chest compressions. C, give positive pressure ventilations with a BVM at 100% O2. Or D, intubate the patient.
Again with the adjectives: wet, slimy, and limp.
Did you write this one?
Yeah, I
too?
was getting a little over.
I like it. I like it.
So this again, I was following the protocol to make this one make complete sense. And if their heart rate is under 100, the next step says to give air, give positive pressure ventilation, bag them for, I think it says 30 seconds, and then reassess and see where you're at. Yes, they may need IM epi. Yes, if they start to have symptoms and get too low, they may need chest compressions and they may need tubes. But the biggest part of this is the next step is kids are really oxygen and respiratorily dependent. So giving that oxygen normally will just fix that. And I'm sure this kid, once we bagged him, his heart rate came right back up.
So normally would you do the positive pressure with the BVM for 30 to 60 seconds? If you've seen the heart rate coming up, just continue at it.
Yeah.
But after 60 seconds, if it didn't increase,
Then you go to step B, which I
would it be
that's
open
the
pressure?
epi.
Okay.
But if you're being handed a wet, slimy baby, you could probably also assume it hasn't been dried and stimulated.
Yes. First step: wet, dry, dry stimulate. It says you warm. No, you warm, dry, stimulate.
Well, then how's it still wet and slimy?
Well, that's
Well, that was
it says
before it said that.
Yeah.
Come on, Brady, read it right.
It's in Nickelodeon.
Green slime.
That's brown.
That's meconium saying it now.
That's not good.
Nickelodeon had
Oh
green.
yeah.
Another PD case.
Nighthawk.
Man, I'm up. Called for a 3-month-old with excessive sleepiness. I know what that feeling is. Story from mom's boyfriend is that the dog jumped on him. On assessing the patient, he wakes up but cries inconsolable. You notice 4 linear marks about the size of fingers on the side of his head and face. Which option would be inappropriate?
All
Check.
right.
Okay.
Again, another inappropriate question.
I know. You get all the inappropriate. This is just classic concern for non-accidental trauma. Dog jumping up and mom's boyfriend, throwing in all the buzzwords, although they don't have to be there, but showing signs, linear marks on the face, and you just want to make sure that you are not leaving this kid with the boyfriend and just driving off. So the inappropriate move would be giving it back to the boyfriend and leaving. Everything else, check a blood sugar, he is successfully sleeping, that perfectly makes sense. You worry about trauma, making sure that you have the C-spine protected, and then obviously having police on scene if you're worried about non-accidental trauma.
Yeah. Keep in mind, we as providers are obligated by state law to report suspected child abuse. It's not for us to prove or disprove. It's just we have a suspicion. Then we must, the onus is on each of us individually as practitioners and providers to make report.
So I'm going to change the scenario here a little bit. What if the boyfriend says that he doesn't want the child transported?
I think that's where D comes involved.
Yeah.
You're concerned about it, you're an obligated reporter, you call the police and say I have concerns of abuse and get them to help you out.
Plus, he has no rights.
He's a boyfriend.
He's a boyfriend.
Got you on that one, Mike.
Can't stump
You
you
can't
guys.
change
can
the
I?
scenario on Doc. Doc 1 at least.
No, it's because we've had these arguments in real life.
Sure, absolutely.
So I always leverage family. Somebody doesn't want to stay in the hospital, fine. Talk with your wife. I'll be back in 5 minutes.
Right.
They're on my side by the time I get back.
Right.
So use the resources you have available. I would not, if you suspect child abuse, I would not leave scene until there's law enforcement. Unless you could, they say, yeah, take the child.
Right, sure.
If there's anything about family with reluctance to transport, I would not leave scene until law enforcement is there and you've given them your concerns.
Perfect.
The other thing I do is I would document the name and badge number of the officer in your report.
Very nice.
Yeah, they're going to take the fall for me.
Yeah, you are protected by state law in 2 ways. One, you're an EMS provider, you act in good faith, you're protected no matter what. The other is you are protected by state law if you report suspected abuse. Family may not like you, but they can't take any legal action against you.
Sure.
Whereas if you don't transport and it is abuse,
Yeah.
Leaves us out there.
and all their state protections are gone.
Perfect.
Who's up? Is this?
Yeah.
Dragon.
I'll go for it. Your patient called for palpitations and chest pain. She is 45 years old, healthy female, and has had similar but much briefer episodes in the past. She has not been previously evaluated for these symptoms. Vital signs: blood pressure 85/60, heart rate between 150 and 170. The patient is diaphoretic and dyspneic. Her rhythm strip is below. What are acceptable treatment options? A, emergent cardioversion. B, Valsalva maneuvers. C, adenosine 12 milligrams IV push. Cardizem 0.25 milligrams per kilo IV push to a maximum of 20 milligrams. Or E, B and D.
This goes against the
gonna say.
question.
Yeah, I'm going against my
What happened here?
precedent. So really, for me, the question is this patient stable or unstable?
Sure.
So
Your pressure is your big deal there, right?
yeah, for me, the patient's, she's diaphoretic, she's dyspneic. I could have thrown in there that she's got altered LOC, but she's tachycardic, hypotensive. For me, she is unstable, and so she requires emergent cardioversion. I think I might emergently cardiovert one patient a year, if that many. But when they come in, it's pretty obvious. So I would not waste my time on Valsalva or any of the other things. And as a matter of fact, if the patient's hypotensive and you give them cardizem, they may become more hypotensive.
Sure.
So I would obtain IV access as quickly as possible, sedate and cardiovert.
Your doorway assessment is going to tell you a lot in this one. When you walk in the door, you're going to see them, their presentation, and you're going to know right away this is a pretty sick individual.
Yeah, this one is sedate and cardiovert. I didn't throw sedation in there. That was kind of hopeful expectation you would do that.
Depends on how nice you want to be. I don't think Nighthawk would do that.
I would too. I'm a patient advocate.
Well, I just think about the patients with the AICDs that are firing.
Sure.
It's bad enough they have to have it. This patient we have to cardiovert, but we could at least make an attempt to sedate her.
Absolutely.
It hasn't been recorded for the last 6.
No, I think we got this one. So, guys, I think for the audience, I'm not very good with audio visual. I stopped the recording for a session, so I think we're restarting where we were. You may see a duplicate slide, but let's go with this one again. If we're duplicating things, I'll edit it out later. But question 16.
You're caring for a 30-year-old male with a history of cocaine abuse and schizophrenia. He is agitated with a SAT score of 2+. You administer midazolam 10 milligrams, IM. 10 minutes later, he remains agitated with a SAT score unchanged at 2+. What should you do next? Administer ketamine 2 milligrams per kilo IM. Midazolam 5 milligrams IM. Another 10 milligrams of midazolam IM. Or ketamine 2 milligrams per kilo IVP.
The answer is another half dose of midazolam. So we're talking about a patient with an SAT 2+. Last year, we had several EMS agencies look at this and say, hey, we have patients, we give them a dose based on this SAT score, and it doesn't give adequate control. Can we redose? What can we do? So we went back, looked at it, and so for a SATs of 1+ or 2+, you can repeat the original medication at half the dose. So if you look at what we've got in the protocol now, we added that you can repeat the original medication at half dose in 10 minutes, whether it's for an SAT-1 or an SAT-2. And the idea really is to stick with what you've given rather than add another medication. There have been reports where if you mix midazolam with ketamine, then your risk of respiratory depression and need for airway procedures goes up. So let's use what we started with and give more. In the emergency department, we'll have patients that may get 20 or 30 milligrams of midazolam IM just because they're wired up between their psychosis and their methamphetamine or methamphetamine and cocaine. So it may take a good amount of medication to get them under. The other thing about it is, at least in the emergency department, many of these patients are hypertensive. We really don't want to give a lot of ketamine to somebody who's hypertensive. We'll use midazolam instead, even if that means using extraordinary doses.
Perfect.
So I think we should be caught up in terms of my errors in recording.
Dispatch a local bar for an injured person. On arrival, police are on the scene with a 30-year-old female. She's in custody and appears intoxicated. The officer would like to take her to jail, but would like EMS to clear the patient before he takes her. Which of the following indicates the need for patient transport by EMS? A laceration above the right eyebrow, sugar of 105, 1 episode of vomiting prior to our arrival, pressure of 110/60, or a GCS of 14.
So for me, the right answer is A, and that's because if you look at our protocol, we have a protocol or algorithm on clearance of intoxicated patients, and one of the excluding conditions is for patient transport by police is any injury above the clavicles. So the Inebriate Center in San Francisco has a similar criterion. So they will accept drunks off the street, brought in whatever way they get there. But if the patient has an injury above the clavicles, they are sent to the emergency department for assessment. These patients, if they're intoxicated with head injury, may need imaging or other evaluation. If you look at the other things that we have as disqualifiers, vomiting is a disqualifier if it's ongoing and active. This patient vomited once before you got there. They're not vomiting now. The finger stick is okay. The blood pressure meets parameters. Their GCS is within parameters. So the patient can be left into the custody of the police. Or if it's a family wants to keep the family member at the house, you can leave them behind. But if you're going to leave them behind, the patient has to be able to ambulate unassisted. They have to have a responsible and sober adult. So that may be a difficult threshold right there, depending on where you are. And the patient needs to be able to acknowledge the ability to, the need to stay with the responsible adult until they're sober. I don't like to take care of intoxicated patients any more than anybody else, but I have a low threshold for making them a medical hold in the ED where we keep them until we know they can be safely discharged.
I mean, the big thing with this is you can't distinguish that head injury from being drunk at most of the time.
Correct.
So,
And we have had a couple over the years, since I started with MEC, we've had a couple cases where patient's intoxicated, is refused, is not transported, and then has a bad outcome a day or two later.
Sure.
We even see that in the emergency department. Somebody comes in, they're drunk. It's one of 5 drunks for the night. We take a look at them, but they don't wake up. We CT them 5 hours later, and there's a head injury. So it's not always that straightforward. And like I know everybody's tired of me saying, my biggest liability is the patient I discharge from the emergency department. Your biggest liability is the patient you don't offer transport or you don't transport.
It's kind of a different feel because in my line, I often bring patients bottles.
see what you did there.
A little bourbon and honey?
We
Yeah,
are
that's
in it
A
today.
little bit of grandma's cough medicine, huh?
You take
Okay.
it if you know it's better for you.
Here's a PD case. PD arrest. It says,
Yeah, on it. You're at the firehouse, and a mother brings you her child who had just collapsed. You find a 4-year-old with no respiratory drive and no pulse. You immediately start high-quality CPR and attach him to the cardiac monitor to see the below rhythm. An IO is in place, and the patient is intubated, and you confirm that there is no pulse. While continuing CPR, what is the next most appropriate step? Defibrillate at 4 joules per kilo, administer epi, 0.01 milligrams per kilo IO using 1 to 10,000. Administer adenosine, 0.1 milligram per kilo IO, or administer magnesium sulfate, 25 to 50 milligrams per kilo IV infusion.
So this goes in recognizing what you're dealing with. These are all great. Every answer A through D are all great resuscitative efforts from PALS, but it's recognizing that your rhythm strip shows a perfect normal sinus rhythm, but you have 0 pulse, and the kid is deadish. It's not moving and has no cardiac activity. So the answer is B. Your first and probably only line besides really high quality CPR is to do epinephrine and then go to try to figure out the causes of it.
Sure. Our H's and T's.
H's and T's.
So our rhythm is going to be our PEA.
Yep.
Epi
Epi.
is going to be our only drug, and then figuring out what our baseline is and why they're in cardiac arrest.
100%.
Sounds pretty easy and cut.
Yeah,
straight
I
down.
mean, it's easy on a question. Real life, it's no different. No second
High
guessing.
quality CPR, which you need help.
That's the key.
More adjectives.
Mhm.
Another PD case.
2-month-old called because of increased work of breathing. She was born at 35 weeks gestation, but has otherwise been doing well. Mom states the whole family has colds, but she is worried because our patient seems to be working very hard to breathe and is not taking a bottle. On exam, she has copious amounts of mucus coming from her nose. On lung exam, the patient is breathing quite rapidly and has diffuse rhonchi and wheeze, along with global retractions. Which of the below would be inappropriate?
Another one.
Another one, huh? I see. All right, I see where this is
Inappropriate,
going.
yeah. I guess the first thing I wonder is why a 2-month-old's calling you.
That's kind of what I was curious. I mean, that's a
Did you
pretty
throw
good.
that- did you
That's
throw that
pretty
in
good
to see if they
parenting.
catch
though.
it?
Yeah.
that's precocious.
Yeah. This is in, I think every year we throw in some type of bronchiolitis case because it shows up every year. And we're just coming off of our bronchiolitis season. Actually, it was early this year. We're just coming off of it. But bronchiolitis in a big person is a cold, but in a little person really makes it hard to breathe. And we've tried every therapy under the sun and found that most don't work. The correct answer of the incorrect response is D, giving albuterol. We don't give albuterol. You can repossess their airways so they can breathe better. The biggest thing for these kids is getting the nose sucked out. They have trouble breathing just because their nasal passages are so small and they're just clogged with mucus. And then finally, give them oxygen. It'll help them breathe and also make them be a little bit more comfortable. But albuterol, we've tried it for years. It does nothing but raises their heart rate, messes up their V2 mismatch, and prolongs their stay. So that would be the one thing to avoid doing in a 2-month-old. under 2 years of age without a diagnosis of asthma, I would say, or hold on, I'll be look.
All right, number 20, you're dispatched on an overdose. On arrival, you find a middle-aged male who is sleepy with spontaneous airway. There is an empty pill bottle with 30 amitriptyline, 50 milligrams, that was filled yesterday. Vital signs are blood pressure 100/70, pulse at 120, respiratory rate at 12, and here's his 12 lead. What treatment do you provide? 500 milliliters IV bolus, intubation, 1 mil equivalent per kilo IV of sodium bicarb, and 150 milligrams IV of amiodarone, or E, A, and C.
How come when I told you that you looked at the doctors?
Because I thought you'd throw something out there that wasn't right.
All right.
All right. So this is amitriptyline is a tricyclic antidepressant. We don't see it as much as we used to. Now it's probably used more as a sleep aid. But in years past, before the SSRIs, like Prozac and the other Zoloft came out, it was a common source of overdose. And we do have it in our overdose protocol, so I thought it's fair game. So, one of the first things you'll see with a tricyclic overdose is sedation. Depending on the amount of drug that the patient took, they can develop decreased respirations. They can become hypotensive. We use the electrocardiogram a lot to determine therapy on these patients. And the things we look for are sinus tachycardia and widening of the QRS. If you see widening of the QRS on a patient, and our presumption is that they typically have a normal QRS before the overdose, but if you see a widening QRS, then we're worried about the progression of the overdose, where it may actually become life-threatening in terms of arrhythmia. The most effective treatments for these patients is IV fluid bolus and then sodium bicarb, which helps reverse the toxic effects on the heart. So, a patient has sinus tachycardia, an Elavil or amitriptyline overdose, we will give them fluid boluses. If they're starting to widen the QRS, we will give them IV bicarb, either as a bolus or as an infusion, or both. So the treatment for amitriptyline overdose or tricyclic overdose is fluids and sodium bicarb.
So for us, we typically see this, we're going to give the fluid bolus followed up with the sodium bicarb, but in the hospital you could see repeats of the sodium bicarb over and over and over again.
Yeah. And there are times, for us, the types of overdoses we see, I don't need to call poison control.
Sure.
I would probably call poison control on this one because it's been so many years since I actually treated a tricyclic overdose. But these patients go south fast. Mm-hmm. And there's some other modalities that we might give them, like lipid infusions, if poison control recommends it. I don't know if lipid infusion is recommended for tricyclics, but there are other therapies that have come out since I did this. So for you, I didn't throw it in there. Ask poison control.
Sure.
I would definitely transport these patients because they need 6 to 12 hours of monitoring.
But as any overdose, we're going to transfuse.
Yeah. So. Well, some of them poison control say, well, if they only took half a pill of this, leave them at home. But if somebody's got an empty amitriptyline bottle by them, or tricyclic, transport. But I would make sure you get a 12 lead and put them on the heart monitor. Little trauma. Who wants trauma?
Preparing to transport this patient from the mountain bike trail with his injury. Patient's pain is uncontrolled. She weighs 60 kilos, which means a pain control is not appropriate. Immobilization, 50 IM of ketamine, 1 milligram per kilo of ketamine IV, 0.3 milligrams per kilo ketamine IV, or fentanyl, 90 micrograms intranasally.
Well, I think I have ketamine up there 3 times, so that should tell you that one of those three is probably incorrect. Just remember that immobilization is an effective means of pain control, and we often forget that. Immobilization is always appropriate. For this kind of a wound that got an open ankle fracture dislocation, I would put a moist dressing on it, use a little saline on a trauma gauze or something. I would immobilize it. Fentanyl intranasally is acceptable. Our protocol says 1.5 mics per kilo intranasally. You can use that for kids too. So which one of those ketamine doses doesn't make sense? Well, 50 of ketamine IM I already mentioned as being effective for burns. It would be effective for her as well. Both 1 milligram per kilogram and 0.3 milligrams per kilograms are legitimate doses of ketamine per protocol, but it's the 0.3 per kilo that is indicated for pain control. The 1 per kilo IV is for behavioral emergencies. So I would, the incorrect answer is C.
I would definitely reference your protocol if you're going to do something like this.
And your partner.
Absolutely.
You know what I mean?
So
Yeah, if the fentanyl actually my choice would probably be just give her the 50 per kilo IM. If you're out on a mountain bike trail, who knows what even you have available?
Sure.
So, but I would immobilize for sure. But any of these treatments are appropriate except for C.
Check for cougars out there too.
Ticks.
Ticks.
Ticks, that's not good. Especially a Lone Star tick, that'd be terrible. Can't eat red meat.
Question 22. You're dispatched to a local bar and a stabbing. The scene has been secured by police. On arrival, you find a 25-year-old female with a stab wound to the upper left chest. Vital signs show blood pressure 80/60, respiratory rate of 34, pulse rate of 120. The trachea is deviated to the right. What is your first course of action? Apply a chest seal to the wound, intubate the patient, decompress the left chest with a large bore catheter, obtain an IV access, and apply mask trousers. I have not seen that one in a long time.
Well, I'm dating myself. I did that one for fun. So, the key word, what is your first action? So several of these things are appropriate. Actually, all of them are appropriate except for E. Mask trousers, the trauma pants. They're probably, you might have one in the station in the closet. They're probably falling apart and they probably smell really bad. But the key question is, what do you do first? So I try to build a dire scenario. Patient's hypotensive, rapid respiratory rate, rapid pulse rate, trachea is deviated to the right. So what do you think they have?
Tension pneumo.
Tension pneumo. So the first thing we need to do is decompress the left chest. That's the life-saving intervention. At some point, you may need to intubate the patient if their condition deteriorates. Hopefully, you'll have the time and ability to get the IV started, and you can apply a chest seal. But the first thing we want to do is decompress the chest, and probably the one of the things you don't want to do is intubate the patient while they've got tension, because then your positive ventilations are only going to make it worse.
I think as you look at everything that's up there, when we initially see the patient, we don't have all those vitals, right?
Yeah.
We can see that they got a rapid respiratory rate, but when you're doing that initial rapid trauma assessment, you should pick up on that deviated trachea, and you should be able to do your decompress your chest, possibly before you even get your vitals.
Yeah.
Based on the fact that you have absent lung sounds on one side and some on the other, and you have a deviated trachea, that's going to be your go-to right there.
Well, would you be happier with this scenario if I said an EMT arrived on scene first and found these vital signs?
Mike's never happy, so you're not going to please him.
It's like the second young lady in a bar that's been injured.
Yeah, what's going on here?
We must do a lot of this.
Yes. All right. I could tell you stories, but this is inappropriate time and place.
Oh, that's Copperhead.
You don't know. Red touches yellow, you're a dead fellow, and that's saying or
That's
something like
coral
that.
snake.
Coral snake.
They're in Texas.
Well, it's still yellow. 16-year-old male tried to pick up a snake in his backyard. Here's what you find. What should you not do? Outline the area of swelling, obtain IV access in the unaffected arm, bring the snake's head with you, absolutely. Immobilize the extremity and administer a fluid bolus as needed for hypotension.
So what's one of the key rules of EMS is don't take one victim and make two out of them. So I think all these things are appropriate except for C. Snake heads maintain the ability to bite even after they've been severed. So, don't put it in a box, don't put it in your pocket. Outlining the area of swelling is important because one of the key features we monitor during evaluation and treatment of patient with snake bite is the area of induration, swelling, necrosis, discoloration. So if you have a Sharpie or your pen, just mark what you see, even if you may see nothing. IV access in the other arm is a good idea. We need good access, and the sooner you start it, the better. You don't ever start it in the affected arm because we don't know how much swelling is going to occur. Immobilization of the extremity is good. Over the years we've heard about, make a X cross over it, suck out the poison, or put a tourniquet proximal, or put an ACE wrap on it. No, it's just keep the patient from moving it around, and then as you need to administer IV fluid bolus. So I thought we'd have a little fun with this one. And,
I think you're taking all the fun out of it.
Yeah. I think this would be a good spot to use the old saying, "Don't bite the hand that feeds you."
Speaking of hands, though, if he doesn't have any jewelry, take them off.
Yes, good
like
point.
That. Good point.
And that's a good point for any hand injury. You get the rings off sooner, because if you don't get them off, they're going to come off in the emergency department, and if there's progression of swelling, we're more likely to have to cut them off.
There's actually 2 snakes there.
Yeah, there's a tail of them.
Yeah.
Well,
But there's probably actually a handful of guys that wouldn't even go into this scenario.
Correct.
yeah.
So this guy's probably not going to make it anyway. 50% of the time.
Well, he walked away.
He walked away.
Walk to the medic.
Got on his hand.
All right, question 24. You're called on a 2-year-old with a decreased level of consciousness. On arrival, she is difficult to arouse and has some cyanosis. Respiratory rate of 8, heart rate of 112, and she has pinpoint pupils. Mom states that she has otherwise a healthy child and has not been sick. She knows she was in the bathroom, but not exactly sure what happened since Mom was in her room resting. Mom had an ankle surgery yesterday and has been non-weight bearing and has been taking Percocet that she was prescribed. Which of the below would be the most appropriate next step? Offer blow-by oxygen, intubate the patient, give intranasal Narcan at 0.2 milligrams per kilo, or establish an IO. Dr. Stoner.
You do get all the appropriate questions, but Brady gets the inappropriate questions. I realize that. This is just taking an adult, not formally an adult problem, but saying that we do see overdoses in kids too. The correct answer is C, give the naloxone. I didn't give you SATs and probably should have, so A is probably an unfair question, but kids get into all types of things, and a mother who's got meds laying around and is not really paying attention leaves that kid to go around and wander and figure out what they want to play with next. So if it looks like an overdose, smells like an overdose, treat it as such, and then you can move on. So that would be the next step I would do. The other stuff, she may need a IV access, IO access. She may decrease and need to be intubated too. These are all possible, but the next step would be try the Narcan.
With a respiratory rate of 8, would it be appropriate to start with bagging her?
Yes. So that's what I said. I didn't give you, and that's bad question writing. I didn't give you a SAT. Had it been a low SAT and she looked like she was distressed, I think totally bag, oxygen, whatever you want to do. I think the key here was to recognize an overdose of narcotic and treat appropriately.
I think you're tacking on to the kid getting into grandma's beta blockers.
Yeah. You can't trust kids.
I'm
That's
aware.
a fact. They get into stuff you didn't even know you had.
Is that your house?
Yeah, yes. That's my trailer when I lived down in Perry County.
Medic is the first to arrive at a home after being dispatched on the unconscious person. This is what the home looks like from the street. What, at a minimum, should you bring into the house? AED, cardiac monitor, dextrose, Narcan, oxygen with a delivery system, PPE, or all the above.
So this really reflects on our clinical standard about what equipment you bring in when you first arrive on scene. So I tried to find the junkiest looking picture I could, because it's going to take a bit of time and effort to get in.
This ain't nothing.
Well, but the fact is, you're going on an unconscious person who could be just asleep, could be drunk, could be overdosed, could be dead. And what you want to do is you want to go in with what you're going to need those first couple minutes, because who knows how long it's going to take to get in and get out. So really the answer for me is all of the above. We occasionally see a run report. Well, we got dispatched on this. We went in. We realized the patient had this, and we had to go back out to the truck to get it. So bring in those things that you think you need based on the dispatch message and prepare for the worst. So, for me, all these things are appropriate. Probably PPE is the most appropriate for me. But you want to take with you what you need to get that patient cared for, at least until backup arrives. So, the patient may be a cardiac arrest. They may need dextrose. They may need Narcan. They may need oxygen with some means of delivery, and you need to protect yourself. There's no reason to think that this house is going to be pristine on the inside.
I think all the things up there are great, but I'd have a really hard time not stopping to take a twice look at that there Toyota pickup truck. The yellow in there.
I was trying to figure the yellow car was.
Is that what it is?
That's a Toyota pickup truck. That's like a 94, 95-ish. Maybe a little older than that, but
I also feel like in the background I should see you with a pair of jorts, no shirt, and a bandana.
Cigarettes and a beer.
Yeah, that's right.
But look at the tires. They got BF Goodrich's on there.
They
Yes,
do.
they do.
A cigarette, a Twinkie, and a beer.
There you go.
Together?
Yes.
And I didn't see the
That's a
stickers.
party.
I saw the car up there by the garage. What is that?
That's like a Lincoln. A Continental,
Oh,
maybe.
Lincoln?
Matthew
And a
McConaughey
Lincoln.
did a commercial with that.
I don't know. There's somebody that's going to see this slide and be like, hey, they're going to rattle it off. 1967 Chevy Impala.
What is in the garage? Probably like a muscle car.
Nothing. Nothing.
All right.
All right. Number 26, you're treating a 76-year-old male for acute dyspnea. He has a history of COPD and CHF, pulse oximetry on room air of 86%. He has diffuse expiratory wheezes. Cardiac monitor shows sinus tachycardia with frequent unifocal PVCs. Which treatment is not indicated? Supplemental O2, amiodarone, 150 milligrams IVP, a Duoneb, or CPAP.
I think this is a pretty straightforward case. And for me, there's no indication of a need for amiodarone. He has sinus tach with PVCs, but what he really needs is oxygen to correct his hypoxia. And Duonebs may be required in order to treat his COPD and or CHF, and CPAP may be necessary to facilitate oxygenation. The primary reason I put this up there was because this year we made some adjustments to the protocol where we removed the algorithm for PVCs. So the only time we have an indication for amiodarone with a patient with PVCs is if the patient has chest pain. So those days where patients have 6, 7, 8, 10 unifocal PVCs in a minute, but otherwise have no symptoms related to PVCs, in the past we would hit them with amio, and the patients arrive at the emergency department, the docs would go, why'd you put them on amio? For us, we're not going to give PVCs that are unifocal, not hemodynamically significant. We're not going to treat them with amiodarone unless it's associated with chest pain. So this patient's got PVCs that may be chronic or may be related to his hypoxia. Let's treat the hypoxia. Let's not worry about the amio.
Right, so without hypoxia, the heart becomes a little bit irritated and they'll throw those PVCs. So correct your hypoxia,
Right.
and it may take care of your PVCs.
Amiodarone in this case, and this question looks straightforward and simple, but it's there to make the point about we've taken the algorithm out for treatment of PVCs.
EMS is dispatched on a shooting. The scene is secure. On arrival, you find a 26-year-old with a GSW to the left mid-thigh with active bleeding. The patient is diaphoretic, non-coherent. Your first action is to administer TXA 1 gram, administer 1 liter of fluid, apply a tourniquet, administer TXA 2 grams, or intubate the patient.
So really, this question has 2 points. One is our first priority when somebody has evidence of massive bleeding is to stop the bleeding. So for me, the right answer is apply a tourniquet if the cops haven't already done it for you. So, if you look at a lot of the information that's come out, particularly like the March program, through American College of Surgeons and so on. It's all about bleeding control of massive bleeding first. Airway is important, but if you are bleeding out, you got to control the bleeding before you worry about ventilating the patient. So the first thing is to apply a tourniquet. The other reason I threw this question up there is TXA is appropriate in this patient, but we've made changes this year, so we're no longer going to give 1 gram, we're going to give 2 grams. So this patient would get 2 grams of TXA in the field. Same infusion rate. You put 2 grams in a 100 cc bag and give it over 10 to 15 minutes instead of 1 gram. You may need to intubate the patient at some point. We do have our permissive hypotension protocol. We'll give this patient enough fluids to get a systolic up to a 90, but we're not going to flood him with fluids if he doesn't need it. So 2 points have been made from this. One is apply a tourniquet as one of your first priorities. It's just like give them Narcan before you worry about ventilating if you have to. But do the tourniquet, and then we're increasing our TXA dose from 1 gram to 2 grams. And I was just today asked a question about, hey, I got a patient who's got a big head bleed, or big bleeding from the scalp wound. There's blood clots everywhere. Are they candidate for TXA? The answer is yes. It's acute blood loss that's moderate to severe, which to me means tachycardia or hypotension. Give them TXA regardless of where the source of the bleeding is. It doesn't matter if it's a head wound, leg wound, whatever.
I think we've talked about this before, and I don't want to get too off subject, but TXA, again, we talked about this the other day up at the firehouse. It's one of those things, looks like a duck, smells like a duck, but you're looking at that, AAA, pain shooting through the back, all the signs and symptoms are there. It obviously hasn't fully ruptured because TXA wouldn't work, but if they're pointing to all those signs and they've got somewhat of a leak and they're starting to go down that path, could TXA do something for that?
It's possible. I mean, TXA has been talked about for using for epistaxis, so you can put a piece of cotton in the nose with TXA on it. You can use it for, they use it a lot in OB, particularly post-delivery hemorrhages, so postpartum bleeds. TXA is given for early. It's been given for upper GI bleeds. Really, the best documentation of effectiveness is for acute trauma with blood loss.
Sure.
So yes, I would. You would think it makes sense. I mean, AAA bleeding out. It may not be your first priority, and it may be a last-ditch effort.
That's kind of what it falls down to, right?
It's not going to kill the patient. It's the blood loss that's going to kill the patient. So, is somebody going to fault you for giving TXA when you think they're bleeding out from a AAA? I don't think so. I mean, like I've said before, we cannot protocolize every potential scenario that you're going to see. So at some point you're going to have to use clinical judgment. If your clinical judgment is this guy had a pulsatile mass, or even if he had a known aneurysm, or I think he's got an aneurysm, give him TXA. Now, if the patient's got chest pain, the question may be then, is it a PE, in which case you do not want to give him TXA, or is it a dissection? I think in that circumstance, I would just transport the patient.
So Doc, just to go over TXA again, TXA is designed so that once we clot, our body naturally would clot and then start to break down the clot. The TXA makes it so the clot doesn't dissolve.
Correct. Okay. Our hemostasis is a balance between clot formation and clot dissolving or dissolution. So clot breakdown versus formation, and what TXA does is it impairs the clot breakdown.
Perfect.
Okay, we got some bonus questions here. So these bonus questions are really, they're there for fun. They're also there to talk about things that we think are worth talking about, but not embedded in the protocol.
Sure.
So it's just, we have 2 of them, and we always have bonus questions just to throw a little extra stimulation in. So the first one is a PD case.
A 20-month-old pulled a pot of hot water off the stove and sustained partial thickness burns to her entire trunk, left thigh, and top of the left foot. Her face was spared. Using the chart below, what is the appropriate percentage of BSA for this patient?
I should have brought crayons.
I like that.
What I'd be remiss as a pediatrician not having some type of coloring activity during our test. This was put out by NCH, one of our burn team, and looking at how do you calculate how much percentage burn you have. and they broke everything up into little boxes, and basically you put an X or color or whatever where the child is burnt, and then from there you can count up the X's or the coloring boxes and know how much it is. So in this kid, we said, what did we say?
Partial thickness burns to her entire trunk, left thigh, and top of her foot.
Yeah. So Dr. Zeeb and I was unclear. It's anterior trunk, so just the front. So when you do all that, trunk, thigh, and then foot, you count them all up and you get 18. So your best guess answer is going to be 20 for a close proximity. So B.
And this is we put this in there because it's not in the protocol. Oh, Nationwide only came out with this the past year or so.
Very, very.
It hasn't been heavily promoted that I'm aware of yet for EMS, but it's a nifty way of doing it.
Sure.
We say if the surface of the palm is 1%, and we start doing our palms, but this is a whole lot easier.
Sure. But if we take this back and we look at the burn that we had earlier in the questions, it's over 10% of the body, so a dressing is not going to be appropriate. The gel dressing.
I would come up with 8% on that. It's 1, 2, 3, 4. It would be 4%.
No. I'm saying this patient.
Yeah, he's
gel dressings are not an option because
Correct,
it's more than 10%.
Oh, okay. Yes.
Dry sterile dressings.
Dry sterile dressings
Pain
and
control.
transport rapidly with pain control.
Yeah.
Good. Okay.
Keep them warm. And kids lose heat faster than adults, and burned adults, burned kids lose heat even faster.
Yeah.
And you throw in the cold weather to keep Brady happy.
Yeah. Well, and I think that's a good chart too, because most firemen like arts and crafts.
Yeah.
Some need a little bit more help staying in the lines than others.
Well, all I have to do is put an X.
I like the crayon
You
idea.
can
I was
color.
going to say that's
Yeah.
a great idea.
I have trouble not
And
eating
all hospitals have crayons for kids. So
them. I'd have trouble not eating them.
You're coming up with stuff in your nose, okay?
so you're one step from becoming a swallower, is what you're saying.
Hey.
Come on now. We're talking about crayons.
All right. Last one here. Bonus question.
Caring for a 79-year-old male complaining of chest pain. He has a previous history of MI, pacemaker, and hypertension. This is a 12-lead EKG. What is your interpretation? A paced rhythm with associated left bundle branch, paced rhythm with concordant ST elevation greater than 1 millimeter and leads with positive QRS complex concerning for STEMI.
So each answer builds on its predecessor. So this is paced rhythm. Paced rhythm gives you a left bundle branch pattern. Pacer wires in the right ventricle. So there's a delay to conduction to the left side of the heart, so you get a left bundle branch pattern. But this is also a patient who's got a left bundle branch pattern, but he also has ST elevation that's concordant or in the same direction as the QRS, the positive aspect of the QRS. So the answer is C, and if you look at this, you can see that those ST segments are up. And if they were isoelectric or at baseline, they would not be elevated. So this is something we look more and more for. In the old days, it was STEMI was considered a STEMI patient if they had ST elevation or if they had a left bundle branch block. Well, it was found that we really have a lot of patients walking around with left bundle already. So then somebody by the name of Scarbosa, and she was an Italian cardiologist, came up with her criteria. And they're assigned points. And the first thing I do when I see a left bundle is I go back. I guess I can't go back. I go back to the anterior chest leads and look to see if there's ST elevation that's going along in direction of the QRS, positive QRS, because that gives me 5 points. So 5 points or more means you meet criteria. So I look for that. Concordant ST depression, I've got pictures next page, gives you 3 points. Excessively discordant ST elevation gives you 2 points. A guy named Smith adjusted this to say modify more than 25% of the preceding S wave. I don't use that one very often. But the criteria are specific, but not so sensitive. So that means if you see the criteria, you have a STEMI. If you don't see the criteria on a left bundle, it doesn't mean they don't have a STEMI.
Sure.
So if it's there, it says there's a STEMI. If it's not there, it doesn't mean anything.
Sure.
And a score of greater than or equal to 3 has a 90% specificity. So this is what we're looking at. And these are the criteria that we talk about. So if you look on the left, normal or paced, you've got the bundle branch, you've got the QRS. If it's going upwards, you have T-wave inversion in the opposite direction. And if you look at the QRS going down, you have T-waves going up. So if you look at the Garbosa's criteria, you get 5 points if your QRS is elevated in the same direction as the majority of the QRS, or the positive deflection. So that's your 5 points. You get 3 points if you have some ST depression in leads V1, V2, V3 that follow a negative S wave or an S wave. Okay, so if you have an S wave and then you have ST depression, that gives you 3 points. So that would also be indicative of a STEMI. And then the last one is the top one, where you have more than 5 millimeters of ST elevation when the majority of the QRS is in the opposite direction, with the modified version being, instead of 5 millimeters, it takes up 25% or more of the total QRS. So I know that may be a little confusing, but it's just something we're going to see more and more. I don't know if they talked about it with EKG training last month at Violet. I think they are going to be talking about it when he comes back in town.
Correct.
But this is something we're spending more and more time on in terms of using Garbosa's criteria to evaluate a left bundle. And I think for all of us as part of EMS, we're comfortable looking at 12 leads. We need to start thinking about those other things that are important.
Sure.
So I know it may seem a little confusing. It makes sense if you think about it. And beware, it's also showing up in the 2023 competency assessments are going to go out. We're going to have this case. So, and there'll be more information on it. So this is kind of the lead up to the one of the 4 competencies for this coming year.
Awesome.
So that's all I have. I appreciate everybody's help and input. We talked about doing this in 90 minutes less, and right now we're at 87 minutes. So thank you guys.
Perfect.
Time management.
Dr. Stoner and I are always available. Send us an email. Although the preference is to submit questions via Ask a Doc on Basecamp. So everybody should be on Basecamp. If you're a new member of one of our departments, check with your EMS supervisor about getting enrolled in Basecamp. We've got 700 plus providers on Basecamp, and it's really a great way to ask questions. So I know Dr. Stoner's answered some questions in the past. I answer them. But if you have questions specific to the protocol or anything we talked about as part of our content today, please post a question on Basecamp.
Perfect. Sounds great. Nighthawk and I would like to thank you both for having us out today.
Okay.
It was a pleasure to sit and go through things with you guys. So
We'd like to thank our sponsors as well. Sherman,
Folgers.
Ultra Strong, wipe away your problems.
And something about Mrs. Butterworth.
Oh,
wow.
Mrs. Butterworth.
I There's
They
supposed
check-
to be an inside joke about that.
There is. The guys here at Violet will understand it. But
Okay.
regardless, that's a big deal. They're not making Mrs. Butterworth anymore.
True.
Change the bottle, right?
Yeah. She gone.
Well, I prefer the real stuff.
Story.
A lot of us can't afford that.